Hi, I'm Debi Buzanowski. I'm the Eddy Alzheimer's Services Director, and Eddy Alzheimer's Services is part of the Eddy system, which is in upstate New York. I'm also the Executive Director of Marjorie Doyle Rockwell Center, and I'm here today to present you with working successfully with people with dementia. I know that more and more of you are encountering clients that have different types of dementias, and working with this population is slightly different than perhaps some of the other populations that you work with. And I want to today just take a few minutes to talk a little about what dementia actually is and what are some of the things that you might see when you're working with somebody with dementia. So to really begin with, it's defining what dementia is. And dementia is a term that's a little bit overused or not correctly used at all. And dementia is really a general term for a whole cluster of symptoms that actually are all part of intellectual functioning. So when you hear dementia, and sometimes we call it dreaded dementia, and that's not what people want to hear as they're aging, but it's usually memory, and that's what people tend to really think of as dementia are memory problems. But memory isn't the only piece to this. In fact, dementia includes memory problems, judgment issues, language problems, decision-making issues. So there's a lot of different conditions that can cause dementia. But the one thing that's important to know and understand is that dementia itself is not actually a standalone disease or condition. Dementia is also not normal aging. So a lot of older adults are told sometimes when they go to the doctor, well, what do you expect? You're 85, you have a little dementia. But that's not true. That's not actually what it is. Dementia is a symptom of up to 75 different diseases. So your clients may be presenting with dementia, or you may be told someone with dementia is coming to visit. It could be a whole host of different conditions. Alzheimer's disease is the #1 cause of dementia. And primarily, if you're working with this population, that's what you're going to see. And a typical Alzheimer's disease starts in the 70s or 80s. And by 85, half of the population that reaches 85 develops Alzheimer's disease. Other conditions you may see that may cause some dementia are frontotemporal dementia. And that's going to look a little differently, and it's also going to involve someone that's a little bit younger. So knowing the type of disease they have and the dementia they have might be important as you're working with these different clients, just because it's going to give you both an idea about maybe their age and some of the things we're going to talk about as we move through these different slides. So in dementia, a lot of times people assume that when they're working with someone with dementia, it's only a memory issue. And that's not necessarily true. Although memory is the big piece and the big element of thought that's impacted in dementia, it's not necessarily always the case. Memory is the #1 thing, but there's a lot of other pieces that are involved in that, other elements of thought, as we like to call them, that are impaired in a dementia symptom diagnosis. Judgment, for instance, making the right or wrong decision. So in the case of working with horses, whether or not they should approach a horse or how fast they should, if they should come up from behind. At home, it's sometimes judgment about whether or not to go outside with a coat on a cold day or on a hot day, sometimes going outside with too many layers on. So that's another piece that's impacted. Attention is another piece that is impacted, another element of thought. And in attention, for you, you may explain what you're going to do, what's going to happen, and you think they're focusing on you, and you find that they didn't pay attention. It's an inability to pay attention. Not that what you said wasn't interesting or important. Their brains are just not capable necessarily of paying attention all the time. So you may sometimes have to re-cue them or bring them back to the activity a little bit. One thing in working with people with dementia is you have to have a lot of patience and really refocus that attention as much as possible. Perception is another element of thought that can be impacted by dementia. In perception, sometimes people with dementia have difficulty realizing whether something is real or fake. how close something is. We're going to talk a little later about depth perception and some of the issues that you can have with that. But in this case, when we look at perception as an element of thought, it's sometimes whether something is real or not real. So they may be presented with a horse and have difficulty believing that it's real or it's actually close. This inability to determine whether perception is real or false can cause a lot of fear in people. So what we try to do is make sure that we're reassuring in that and understand that it's not necessarily fear, it's just this uncertainty whether something is real or fake. Sometimes also they're going to have perceptual issues about the area that they're around. They may feel that the farm or the barn that they happen to be in may be not real or could be fake. And again, it's a lot of reassurance in patients here with the people that have dementia. A big piece of this element of thought that's impacted is reasoning. So our ability to reason is to be able to look at facts and decide whether something is a good idea or is real. Reasoning is something that's impacted fairly early in the dementia symptom process. So this is sometimes why people make poor decisions, or they reason and they can't come up with sometimes an answer. So if you're working with a client and you're dealing with horses, in this case, perhaps they're reasoning whether it's safe to approach a horse or whether they should approach from the back, from the front. Their reasoning may be off. So sometimes you may look at that and say, I can't believe that they would think that was okay. It's not that they can't, it's just that ability to reason whether something's safe or not safe is taken away from them. Another piece is organization of thought. People with dementia symptoms have difficulty organizing not only their thoughts, so their speech may be kind of garbled or out of sync, but they also may have difficulty with their organization of movement. So they may know how they're supposed to approach or how they're supposed to put their hand out to touch the horse or to feed the horse. But that organization of thought and movement does not necessarily work for them. So their movements and things like that are all off and kind of, again, garbled. So they may approach very quickly, or they know they're supposed to stroke the horse in a certain way and they do it differently. And a lot of that is due to the fact that their brain can't organize the steps that they should be taking. So just be aware, even though, again, you've seen them do it 100 times correctly, that organization is not always there. They have difficulty thinking in the abstract as well. So if you're thinking about something and say, oh, what if we did this? Or wouldn't that be great? For them to think outside of the current moment is very, very difficult for them. So the best thing to do is to work in the present and the here and now. For people with dementia to think beyond that and to think abstractly is very, very difficult, if not impossible, as the disease progresses. One of the other pieces of this element of thought that's impacted by dementia is language. Depending on the disease that they have, their language skills can begin to fade even in the early stages of the disease. So they may have difficulty putting words together, thinking of the right word. They may speak in what we kind of call word salad, so it's out of place. We're going to talk more about some of those language difficulties, but when language is impacted, it's extremely difficult and frustrating both for you as a therapist and also for them as a human being. Communication is one of the biggest things for us as humans to talk about our needs, wants, likes, dislikes. So when language is impacted, it can make things very difficult, but I'm going to talk in a bit about some ways we can work with that. So in cognitive decline, these changes and the dementia symptoms you'll see, there's a couple big changes happening in the brain that really are at the cause and the root for this. The first is short-term memory, and that happens in the hippocampus. So the hippocampus is in that inner brain, and that handles our short-term memory processing. Our frontal lobe, which I call our master and commander lobe, is responsible for your behavior, your decision-making, your rational thought, your personality, some of that judgment. So all that's happening in the frontal lobe, and that tends to be attacked very early on in any of the disease processes that have dementia symptoms. The final area that tends to be attacked is the temporal lobe, and that's that language center I talked about. Not only producing language, but also interpreting language. So it's not just their language that's altered, it's their understanding of what it is that we're saying. So our short-term memory is usually the first thing that people talk about being impacted. And the short-term memory system is really what's holding on to things for a very short period of time. What did you have for breakfast? What did you just eat for lunch? What did I wear yesterday? Things that are kind of small in scope, but they hold on to it for just a short period of time. Our short-term memory is also very good at knowing that if it's something important, it'll store it back in long-term memory. Most of our day-to-day life, though, our short-term memory holds it for a little while and then moves it on. The memory centers for this are being destroyed in almost every cognitively declining disease that has dementia symptoms, Alzheimer's disease being the one that we hear the most about regarding memory. So short-term memories aren't even forming, and they're only staying very, very briefly. So something you just told them, the directions, for instance, are gone just seconds later. Okay. Every single client you work with is going to be different in what their memory abilities are, but this is a pretty central one, is that short-term memory. So forgetting directions they were just given. So you may have gone over exactly what you want them to do or what you're going to do with them. If it's within 30, 45 seconds later, there's a good chance that they've forgotten that. They may ask questions repeatedly. And I mentioned patience earlier. This is really where it comes into play. They are going to ask the same thing over and over again. They may even say that you're not answering them, even though you've answered them 4, 5, 20 times. So they ask questions over and over again. They also have difficulty understanding the passage of time. So they may ask you, when is this over? Or when is someone coming to get me? Or how long do we have? Giving them a time period and saying, 20 minutes, 15 minutes, that doesn't work. They don't understand that. So the best thing to do is say sooner, soon, later, in a little while. They understand that better than they do a specific amount of time. So in short-term memory impairment, those are some of the things that really tend to be difficult for us as we're working, especially one-on-one as therapists and direct care providers. And they do wear on the patients. It's very difficult sometimes because you just answered a question, you just told them, and you want to say, we just told you that. But again, that's because they don't have that memory center. The interesting thing about a lot of the dementia symptom diseases is that long-term memories actually stay longer. Alzheimer's disease and some of the other diseases are actually philo diseases, first in, last out. So the first information, the most recent information, so the directions you just gave them, are the first things to go. But stuff from their childhood and their past, that's in there pretty deeply. That's why their long-term memories tend to stay. They become a little less clear as the disease progresses, but you'll hear that. They'll tell stories, perhaps, if they were raised on a farm or if they've been a lifelong horse lover, about horses in their past. The more you see them and as the disease progresses, what happens is that their stories become less defined or less clear. So they may remember they've ridden a horse, they grew up on a farm, and they may tell you about that. The details may begin to fade, but that memory is pretty solid in there. So the long-term memories are usually the last to go. One of the things, though, with long-term memories is that sometimes in this disease process, we talk about, especially in an Alzheimer's or a declining cognitive degeneration disease, we're seeing that they're going back in time by decades usually. So sometimes they're going to be talking to you as if they do currently live on a farm, thinking they are maybe in their 30s or 40s. So they may talk about living on a farm, and you may know very well they don't. And we're going to talk in a little while about some of our fibbing, but that's being present with them and saying, oh, that's great, and kind of going along with that. So how do we work with somebody with short-term memory loss? The first thing that I always tell people to do is to eliminate as many questions as possible. Questions cause anxiety for people with dementia. They don't know what just happened, what you just said to them, what was just going on in their world. So when we ask them a question, aside from how are you today, which is reflexive, they sometimes go to automatic answers of I don't know, no, or they shut down and don't answer. We see this a lot when families come to visit, say, at a facility. How are you today? What did you have for breakfast? What are you doing today? Too many questions in a row. They get very anxious. Anxiety will shut somebody down with dementia, and they can either sometimes really just shut down completely and not engage with you, or they can become very frustrated because they know they should know an answer, but they can't give it. Other things that I really encourage is try not to use phrases such as, don't you remember? I just showed you how to do that. Or don't you remember last week? They can't do that. They can't remember. And that's at the heart of a lot of the disease processes we're talking about. So don't you remember is just a really difficult phrase, and it's just hard for them. I've heard some folks say, no, I can't remember. That's what's wrong with me. So don't you remember is one of those phrases we try not to use. Also, I just told you. And that's hard because it really tries on your patience when you're working with someone, especially one-on-one with dementia, because you may have just told them 5, 6, 7 times, but they're asking the same question again. So saying things like, I just told you, again, isn't helpful because they don't have that ability to recall or remember. Other things, if they're coming back after you saw them a week ago or 2 weeks ago, things like, you know me, what's my name? Those are things that, again, they don't necessarily remember. If you want to put yourself in their shoes, some mornings they wake up, they don't know where they are, who the people they're living with are. They're certainly not necessarily going to remember you. And that's not a reflection on you. Again, it's part of that disease process, and we really have to understand that. So sometimes when we say things like, you know me, we met last week, I just told you that, don't you remember? We're asking them to do something that their brain really has just taken away the ability to do. When the disease process tends to move into the frontal lobe, we see that the brain's control center is now being affected. And as I kind of mentioned, some of those elements of thought, that's where they sit, is in that frontal lobe. So loss of attention. They're going to need a lot more cueing and reminder to focus on things like eating or brushing or whatever it is that you're helping them to do with the horse or even with themselves. Button up your coat and you turn around and they're just standing there with their coat still open. So sometimes they need more cueing on that. Something that we see happens with frontal lobe folks is crude or inappropriate language and behaviors. So sometimes that frontal lobe acts as our filter. And when the frontal lobe is affected in one of these disease processes, what happens is they kind of let the gates open. So whatever they're thinking, whatever they're feeling, whatever they may want to say or do, they do. And so what can come out sometimes is some crude or very inappropriate things. And it is easy to say don't take it personally, but sometimes they can be very hurtful. They sometimes name call. They certainly tell you things you don't want to hear about yourself, but you really want to just be aware that that is a possibility. In most cases, when they're engaged in something like taking care of a horse, being active and outdoors, that doesn't tend to happen, but just be aware that it could. And again, it's not just you. It's that filter gone. I would bet that when their brain was fully intact, they never would have said the things that they're saying, but you just need to be aware of that. They may make poor judgments and decision making. And one of the things here to think about is even though they may have been raised around horses their whole life, they may make decisions. They, perhaps have always taken care of horses. One of the things that you want to really make sure that you're checking is kind of their hazards and their ability to make good decisions in the moment, such as not walking right up to the horse or coming from behind or reaching for them. So the poor judgment and decision making, unfortunately, is part of that disease process. Another thing that can become frustrating and really does try sometimes on our patients is that difficulty following directions. Oftentimes we have to break things into one step at a time, and a lot of that is due to the fact that they can't sequence. So what we would think as simple as brushing our teeth, they sometimes have difficulty doing because it's multi-step. So even though you may say, I just told them, pick up the bucket and grab the brush, they may be lost already. So we really have to make sure that we're understanding that we have to do one direction at a time usually. So when we're working with folks with, again, frontal lobe impairment, the mood swings can come up. So they may be laughing and loving and enjoying the moment, and then suddenly they're crying or they're very angry. What's happened is the frontal lobe, which normally would regulate that, is no longer able to. So our mood swings and personality, we sometimes see those go up and down and up and down. Don't take them personally. And again, that's easier said than done sometimes, especially if you see someone start crying or get very angry. We can't say for sure why or why they're upset or anything like that, but we just need to know that, again, it's that frontal lobe and they really have kind of a loss of control over that. If they do get upset, they become angry, they're crying, validate and acknowledge their feeling. I'm sorry you're upset. Oh, I know it can be very, very difficult. Give yourself some space, give them some space, and reapproach in a few minutes. But certainly giving them some space and making sure they're safe and you're safe is the best way to go about that. But unfortunately, their mood swings and personality changes can't always be, be predicted. Like I said, they can be having a great time and suddenly they start to cry. And it's not because a memory suddenly hit them. It's sometimes just they have no control over that emotion pattern. Again, decision-making becomes really, really important here. They may make decisions that aren't safe. When you're working with a client with dementia, you have to be constantly vigilant. And even though you may say, well, they're in early stages, they've worked on a farm forever, they grew up around horses, all of that kind of goes out the window when we're talking about dementia symptoms. So they will walk behind a horse. They'll attempt to feed, touch, anything with the horse, even if it's unsafe to do so, even if the ears are pinned back or it's just kind of giving that look of fear, they may still approach it. Again, that decision-making ability has really been altered in that case. Their behavior may also sometimes be inappropriate or, oh my gosh, I can't believe they said that. They don't have a filter anymore. They're not sure what they're saying or not saying. The worst thing we can do is try to chastise them or tell them that's inappropriate. The best thing we can do is ignore it and move on, or redirect them and re-engage them in working with the horse or something at the farm or the barn. So again, it's not just you, it's that filter more than anything else that's really gone. So for them, they probably wouldn't have said that 20 years ago or done some kind of behavior 20 years ago. They don't have the capacity to understand what's appropriate and what's inappropriate anymore. So we really have to understand that for ourselves. And we're kind of always being their hazard and their constant watch for them. As disease progresses, it tends to move into the temporal lobe, and that's where that language issue comes into play. So when the temporal lobe is damaged, this is where we see some of the language issues develop, and we have difficulty finding the right word. So it appears like the word's on the tip of the tongue. And just for us as younger folks that don't have dementia, we'll lose words too. The thing is that we usually find the word or the name we're looking for, even if it's a few hours later in the shower. People with a dementia-inducing disease typically don't have that. So they're going to be searching for that word. They may do more gesturing or pointing. Sometimes about 65 to 70% of people with Alzheimer's or an Alzheimer's type dementia may eventually stop talking or speak only kind of in that word salad or one-word phrases. So what happens is we have to interpret what they say or kind of read their body language. And actually reading tone and body language is really important in working with people with dementia. The frontal lobe, which would have helped regulate that, and the temporal lobe, which is working on language, they're not working together any longer. So for them, it's very difficult. So when you're working with somebody with language center issues, there's a couple things we need to keep in mind. They sometimes begin to forget or lose words. So for us, you can simply fill in the word and continue the conversation as if nothing was amiss. I used to have a client that used to always call coffee shoe, and he'd look for a cup of shoe. And at first we weren't really sure what he was looking for, but he kind of cued us to what he wanted, and we just went on as if nothing was amiss. And sometimes that's the best thing we can do, is just help them along so that they understand that we're listening. So fill in a word where appropriate, continue as if nothing is wrong. That's usually the best way to go about something. We need to learn to speak a little slower. We love to talk fast. We have a lot to say. But for people that are having cognitive issues, it's very difficult sometimes, and we have to slow down. So we need to speak slower and use less words. I'm going to talk in a little bit about something we call our 7 and 7 rule. 7 words or less, and pausing for 7 seconds in between. As diseases progress, sometimes we really do need to watch that, because some people in this disease process will always have language abilities, and they don't need us to change how we speak. Others, we have to alter our speech patterns immensely. One of the things I did mention is sometimes they lose the ability to speak. One of the conditions that can actually cause dementia symptoms are strokes, and losing the ability to speak is very popular in stroke patients. So we have to be aware that they may not have the ability to speak. So again, using sometimes the tone of a sound, a grunt, a one-syllable utterance, and that body language is actually going to be the best thing that helps you. So there's no mistaking someone's face when they're very excited or when they're scared or upset. So you're going to be watching for that, even some of the body posturing, arms across the chest or anything like that. So all of that comes into play when you're working with people with dementia. I mentioned earlier that there's some other changes. In particular, things we look at are visual changes. Typical dementia client is aging. We all are, but they typically are aging, and they're in their 70s, perhaps in their 80s. So they're also already experiencing visual changes, auditory changes. But here, when you add in the dementia component, it's even more advanced in that way. One of the biggest issues is in peripheral vision. For somebody with dementia, as the disease advances, it appears to them as if they're kind of walking around the world with blinkers on, just like your horses sometimes. So they will not necessarily see something coming from the sides. So you always approach from the front, and that's for both you, and if you're bringing a horse along to them, come from the front, or else you'll be scaring them. Same thing as if you see them at the farm and you're approaching from the back. If you were to just go up and tap them on the back, you may startle them or scare them. People with dementia are not going to be able to come down from that anxiety or that startle the same way that you or I would. They can become very anxious from that. So always come from the front. If you want them to see something or hold something, present it directly to them, in front of them, so that they can see it. Coming at them from the side or holding something out to them from an angle, they may not see it. People with dementia have difficulty seeing in 3 dimensions. This is, again, where we have to be on constant hazard watch. They don't see sometimes gradient changes. I know that at farms, the dirt roads and barns can sometimes be up and downs. We have to be really aware. They may not see the cues that suddenly we're on a ramp, or that there's an indent in this dirt, or whatever that happens to be. We have to be watching for that. If they walk with a cane or a walker or anything, they may get hooked on things and they just keep going, which can be extremely hazardous for them. One of the biggest visual changes is in visual perception. People with dementia have visual perceptive changes in that water can become very frightening because they don't necessarily see it or interpret it. So a puddle just looks shiny to them, could look very slick to them. They may be hesitant to go near it, through it, around it. Water is just one of those things that perceptually looks different in the brain for them. So we really try to, again, consider that they're looking at the world differently. Shadows to them sometimes look like black holes on the ground. So a shadow being cast outside by the sun may look like a hole, and you may have a dementia client attempt to jump over that hole. Or they may be hesitant to enter a stall if they see any kind of black area where they think that you want them to walk across something. So again, their perception of the world does not look the same as ours. So you have to be aware of that. Again, their hesitancy to approach or to come with you may not be any fear of you or the horse. It's that the environment looks kind of weird to them. Other sensory changes that they may have are things like hallucinations. 75% of people with dementia will hallucinate. So they may tell you there's something else in the stall with the horse, or that they saw something off to the side. I usually tell folks to go ahead and go along with that. Trying to tell someone that what they saw wasn't there is reasoning and logic, and most people with dementia symptoms don't have the ability to do that. So it's easier to go along with the hallucinations and to kind of buy into them at the moment. And like I said, we'll talk about therapeutic fibbing, but it's really the best thing that we can do sometimes. Other sensory changes, again, are some of their diminished senses. Taste, which may not be as important for you, but their taste is changing. Their sense of smell is being altered. Their sense of touch may be altered as well. They may not be able to tell you necessarily what they're touching. On the other side, their sense of tactile need may be increased. So you may see them wanting to rub the horse and rub the horse and rub the horse, and that may be the only thing they want, because that feel of that really is something that they're getting a real benefit from. So just be aware their senses are changing. It's not just a mental thing. It's working through the whole body, a lot of these changes. So when I start looking at what are the key things to tell you, first and foremost, every interaction should be like it's your first, even if you just saw them the day before, even if you went away and came back a couple hours later. Introduce yourself and say your name. The best thing you can do for someone with dementia is say your name over and over again. They're much more likely to do something if they know you, and their ability to recall a name isn't there. So saying your name as much as possible is the best thing to do. Worst that happens is they're going to say to you, I know you, and that's fine. Break those tasks into very simple steps. One direction at a time is usually what I tell people to do. So just one step at a time. And again, you may have to repeat that over and over again. Your dementia client each one is going to be different. So some of them you can give a whole list of directions to. Others, it is one step at a time. What you may find is over time, that person that you've always been able to do 3, 4, 5 steps at a time with, that's going to change, and they're going to become those people that are those one step at a time kind of clients. Cueing becomes really, really important. So visual cues with verbal instructions. So if you're talking about brushing, make the motion as you're describing it. For them to see it and to hear it is sometimes the best way for them to understand what's happening. If they're unsure or they're not sure what they're supposed to do, hand over hand interaction is sometimes the best way to do that. So actually putting your hand on it and doing something together can be the best way to do something. Feeding, okay, for feeding an apple or something, putting your hand with theirs. If there's somebody that grew up on a farm that's always had horses, that hand over hand or that kind of starting it for them sometimes, what you'll see is that their brain will suddenly click and they'll pull away from you because they've realized that memories come back and they know what they're doing. But the best way to start it is with a hand over a hand or starting the activity for them. Redirecting is sometimes important. Something else in the environment may catch their eye. As I said, their attention span is very small, or they may get really attached to one thing and you're moving on to something else. So redirecting them becomes important. And to do that is really just getting their focus, saying their name, and kind of redirecting them back on what we're doing. No scolding or, hey, look over here, didn't I just tell you? A lot of times cueing can be that. And again, placing their hand on something you want them to focus on can be a great way to do that. If you're working with a client and there's 2 of you working with them, only one person should be talking and giving instructions at a time. As soon as there's multiple people in an environment, it can really confuse somebody with dementia. So you want to be really, really careful that it's one person doing the talking and the instruction giving. So when you're conversing with somebody with some dementia symptoms, again, it's going to depend on them. Every disease process looks different. Every client's going to be different, but you really want to look at some of the different communication styles. And one of the things that we try to think about is as that disease progresses, even though you may be having no communication problems, you may need to alter that as the disease progresses. So the first thing you can do is describe what you're about to do very simply. And simple is very difficult for us in the cognitively intact world. We love to talk. We love to use a lot of words. So when you're describing something, using the most basic and simplistic approach is usually best. That's why I said using a 7 and 7, 7 words or less, and pausing for 7 seconds not only uses less words to do something, but it also gives them time to respond. So that 7 and 7 rule is, instead of handing them, say, a brush and saying, here's a brush, go ahead, and why don't you just start brushing here? Way too many words. So breaking that up into, here's a brush, 3 words, they'll take that brush, and when you see that they've acknowledged that, start here and show them exactly where. What you're doing is breaking up the sentences and all the words you want to use into something that's much more manageable for them. So again, it's what we call our 7 and 7 rule. Make eye contact and make sure they can see your face. For someone with dementia, it can take up to a minute for them to actually put together a human face. So you can be talking to them, engaging them, telling them what to do, and they may be smiling at you, and it's as if they've never seen you. But suddenly it clicks that you're a person talking to them, and they may even say to you, hi. It's because their brain just put together that human face. So make sure that they can see it. We talk about getting low. If they're seated, or if they're in a wheelchair, you want to make sure that you're getting down when you're talking to them so that you're at eye level with them. It also lets them have an equal share in the conversation. But make eye contact. It's also socially acceptable. Use concrete language, not jargon. So as this disease kind of progresses, what we see is that they are going to the very basics of language. So saying things like, oh, that's awesome, that would be cool. Slang really doesn't work for them. You need to be very concrete about what it is you're saying and what you're describing to them. As I said previously, fill in the gaps. Certainly if they're having language difficulties, just act as if nothing is happening and try to fill in for them. Avoid talking to them like they're children. One thing that people sometimes don't understand is when someone has dementia, they're not the same as a child. So we don't talk to them in baby talk or a childish tone. We don't treat them like a small child. Although that brain is regressing, we don't talk to them on a level that you would a small child. Yes, you're doing a lot of skills similar to working with a younger population, such as repeating directions, one step at a time, approaching slow, but they're not children. So you want to avoid that baby talk or some of that childish kind of tone to the voice. You want to use positive wording and not negative. Obviously, if they're in danger, you certainly want to say, no, don't. But using the words no, can't, no, don't do that over and over again can become discouraging and very frustrating. And sometimes people will shut down when they're engaged in that. Something that I've mentioned numerous times, but I don't think I ever can say it enough. When you're working with someone with dementia, they cannot just snap to our world and make the brain suddenly work perfectly. We have to step into their world. And so the person with dementia may not be aware of time and place. They may think that they're younger. So they may think and wonder why they can't get on the horse. They've always ridden horses. They ride horses at home. Again, they may think that they're 30 or 40 and they're on their farm. They may even think that they're kids and that they're on the horse farm they were raised on. So they may think they're younger than they are. They may get angry that, you're not allowing them to do something that they've always done. So you just want to be aware of that their world and their sense of what time and place is different. They may think you're someone that you're not. They may call you their parent or their best friend from childhood. Even if you say, my name's Debbie, they may call you a whole host of different things based on where they are in that disease process. So what do we always talk about is stepping into their world, not bringing them to ours. So to step into their world, what that means is if they think that, we're their parent, then that's great. That's who we are in the moment. We just operate in the moment with them more than anything else. So if they think they're on their family farm, sure, that's where they are. We don't want to go into the fact that, no, it's 2018. This is, I live here and you live in a facility or you live with your daughter. That's not what we want to do. We want to enter their world. So to do that, we sometimes have to pretend. And sometimes you're pretending someone you are not. And it seems kind of out there, but it's again keeping anxiety down and kind of keeping them happy and keeping them in the moment and engaged. Answering to a different name. Sometimes that happens because they can't remember our name. They think we're someone that we're not, or they didn't hear your name correctly. If it's that important to you, you can go ahead and keep introducing yourself, but understand they may not necessarily connect that and make that your name. They may see things you might not see, as I mentioned. So go ahead and agree. Oh, yep, I saw that too. One of the things that is sometimes difficult in working with people with dementia is that we have to sometimes tell fibs. And we call it therapeutically fibbing. It's not lying. Lying is mean. Therapeutically fibbing is just bending the truth so that they are not, they don't get upset, that they don't have, mood alteration. So we fib sometimes. And we say things like, yes, this is your family farm. Sure, I'm your best friend, Betty from childhood. Or, oh, that's your horse over there. We bend the truth a little bit. And again, it's not lying. It's just therapeutically fibbing. And sometimes we do that to keep them safe. It's a way that we sometimes have to tell them no, which can sometimes be really hard. They want to do things, engage in things, be active in things that we can't. So we have to sometimes therapeutically fib. So why do we do that? It reduces anxiety, keeps them in a positive, keeps them in the moment. And that's really, really important. Sometimes fibbing prevents arguing and confrontation. And I call the yes-no debate. They say they want to do something or they didn't do something. I want to brush the horse. You just did that. No, I didn't. Yes, you did. No. The yes-no debate becomes very frustrating for them, for any of us. We have it in our own homes when we have fights. Yes, you did. No, you didn't. Nobody wins in that case. So sometimes to prevent that, we have to fib. Oh, the horse's fur, if it keeps getting brushed all the time, its coat, it's going to get all damaged. Those are the types of fibs that we keep going on and on about, rather than saying, you just brushed it for an hour. We alter that and come up with a little bit of a fib. It takes work, and some of us aren't great liars, but we have to learn to bend the truth a little bit. Sometimes therapeutically fibbing can de-escalate a situation. It can prevent some different aggression and issues. It makes them feel safer too. If they feel that you're on the same page as them, or if they think you're somebody, it lets them connect with you sometimes better. It takes creativity, but it does let them, tell them what they want to hear. If they want to ride a horse, you tell them, sure, I'm just going to check it out. Probably have to do it tomorrow. You're telling them what they want to hear, but again, it's not necessarily telling them no. Sometimes you have to be the good guy and make someone else the bad guy. I want to ride. I want to talk to this horse. I want to do this. Sometimes you have to say, oh, we can't. Farm manager says so, or the doctor said. So sometimes we have to bend the truth and kind of make other people the bad guy. It's an us versus them situation. Sometimes asking permission on their behalf. Oh, I'll have to check with the owner of the place to make sure that's okay. Sometimes given to their wants, I always say, oh, we'll go ahead and call them. You can make a fake phone call anywhere with a cell phone. But sometimes giving in by fibbing is good. Oh, I want to go down to the barn over here. Oh, God, it's locked. Doors can always be locked. Equipment can be missing if they need to use it. So certainly, sometimes those fibs are for safety. The best way to really get around them trying to fib them is engage them in something else. So directing them to another activity or showing them something different can usually get them off of a topic. There's ways that we can say no, because a lot of times we have to say no for safety's sake. So saying things like, I wish I could. I'm not sure about that. I'll find out. It's too hot. It's too cold. It's too rainy today. Or, oh, that sounds like fun. Let me check on it. Or, oh, that's going to take some planning, can sometimes be the best way to deal with the situation. So again, no doesn't necessarily have to be no. It could be maybe. And that's sometimes the best thing for somebody with dementia. When they hear no too much, they can become very frustrated and they can shut down. The last thing I just want to really bring up is the fact that we just don't argue or confront with people with dementia. You're not going to win an argument with somebody with dementia. It's impossible to win an argument sometimes with people that are fully cognitively intact. You're now attempting to argue with somebody whose brain is now damaged, possibly up to 50% of the brain not even working. So you're not going to win an argument with them. You're not necessarily going to convince them of your point of view. Again, we have difficulty doing this with people who are cognitively intact. It's going to be difficult enough. So don't try to get them to see it your way. More often than not, if you get into an argument with someone with dementia, there's frustration, there's failure. The person becomes defensive. They may not want to engage. So they come all the way out to the farm or the barn to work with a horse, to have this therapy session. And then they start arguing and you and they kind of have a confrontation. They may just go back in the car and the whole session is kind of ruined. So we really try to prevent that. The way I always say is to learn to say, I'm sorry a lot. I take the blame for a lot of things. I'm so sorry that happened. I'm so sorry about this. I'm sorry. Saying I'm sorry a lot is really an important thing. If you can make it that the issue they're having is your fault and certainly not because of them, we're a lot better off in that way. So learning to say I'm sorry is really, really important. And as I have on the slide, there's Queen Elsa from Frozen, because a lot of times I just tell people to let it go. If they're upset about something, don't engage them in it. Don't confront. Just let it go. Let go a lot of things. Just let it go. Let it go. Let it go. But if you're patient and you use some of these strategies, I think you can be very successful in working with people with dementia. Thank you.
Well, and with that, Debbie, thanks for a tremendous presentation. And we do want to pass along a couple of announcements or a couple of different reminders for our attendees. We do apologize for some of the technical issues that may have occurred during the first part of this presentation. And I want to let you know, too, if you've joined the conference via the guest link, you will be asked to log in once again when you go to your next breakout session. And again, apologies for any misunderstanding on that particular point. As a reminder, Q&A located on the right-hand side of your screen. We have a few moments remaining with Debbie to submit a question. Type your question in the small text box at the bottom. When you're finished, click the send button. If you would, please note that due to time constraints, we may not respond to all the questions that are submitted, but please take advantage of the time we do have remaining for us to be able to answer any additional questions you may have. Debbie, I'll welcome you into the conversation. Looks like as if we have a couple of different questions that have already populated, so I'll turn things back over to you.
All right, sounds great. Thank you. Thank you all for attending today. I hope that you found this informative and that there's some stuff there that you'll be able to use. So I got a question. Is the brain capable of repair when someone has dementia? Because there are over 70 different diseases that cause dementia symptomology, in some cases we see that when they're on meds or something has changed in a disease process, there can be repair. In a typical Alzheimer's type dementia, which is what most people are going to probably see, unfortunately at this time we do not see a repair of the brain when that happens. So that's not possible right now, and that's what a lot of the research that you may read about is going into, is looking at how to kill off the plaques in the brain and to regrow or reconnect some of those brain cells. But as of today, we do not have that. So I hope that answers that question. I had another question. I use many of these same communication diffusion strategies with my students with traumatic brain injury. Do you see correlations between these two populations? So the answer to that, absolutely, 100%. In both cases, you're talking about disorders or diseases where you are losing brain mass, brain tissue, and disconnections of those brains. So using some of the same kind of techniques is obviously going to be very helpful. And a lot of these techniques I talk about, slowing down our speech, approaching from the front, and some of the talking that we do, all of that stuff works wonderfully for multiple populations. So certainly if you're using it with one population, it could certainly overlap to another population. So again, I always say these are just some great ideas. What you may be using with one population may actually work better for working with people with dementia. So certainly try different techniques, and every single person you meet with an Alzheimer's or a dementia diagnosis is going to be different. The next question I got is, how do you redirect a frightening situation that won't go away? Unfortunately, you can attempt to redirect someone so many different ways, and you can attempt therapeutic fibbing, you can attempt reapproaching. Unfortunately, in this case, if that person is very upset, that they're very frightened, sometimes the best answer is to actually kind of remove them from the situation. So the other thing to think about when working with people with Alzheimer's and dementia symptomology is sometimes we are so excited to be working with them, we're so glad they're coming out, but today may not be the day, or that visit time may not work. And so it's okay to say this might not work and to remove them from the situation or remove the situation. Sometimes if it's something where they're about to get physically hurt, they're not listening, sometimes we do need to, guide them more than talk their way through it or logically talk the way through it. So sometimes if redirection and all your tools aren't working, just removing completely from the situation may be your only option at that time. Someone said, I was uncomfortable with the concept of therapeutic lying. Is this common? Yes, more than you know. A lot of my staff, says, I can't fib. I can't lie to my dad, my mom. I can't lie to somebody older than me. Yes, it is lying. It's fibbing. You're telling stories. But the way that I really try to tell people to kind of think about this is that when you're telling those stories, when you're fibbing, you're attempting to either de-escalate a situation or in some cases relieve anxiety. For people with Alzheimer's and Alzheimer's type dementias, when they're anxious, they don't know how to express it sometimes. They're not sure what they should be doing in that moment. Anxiety for them is something they have very little control over. They have a lot of difficulty working through it. So for them, anytime you can put them at ease, and a lot of times putting them through ease is by doing some of that fibbing, you're not doing it to be harmful. You're doing it to try to help them. And it is uncomfortable. It's something that takes some getting used to. So I really do hope that, in time, as you're working with more people with Alzheimer's and dementia, you become more comfortable with that. But it is tough to get used to. I often say when working with people, at one time you were able to lie to your parents as a teenager, tap into that a little bit, some of that storytelling there. The next question I have is, do you see positive impact with music in barn with this client population? Music is stored in a completely separate portion of the brain. The portion of the brain that's engaged in music is stored totally separately than some of our memories. That is why people with Alzheimer's, specifically Alzheimer's, have music has such a great impact on them. If you are playing music in the barn, it should be relatively to their time period. You're not going to play, pop hits of today, but music can be just a wonderful thing to help them enjoy the experience. The only thing I would really watch out for is if you're giving direction or attempting to engage them, the music and the noise may actually override that, and they're not able to actually do both, listen and engage in the music and participate. So if they're there and they're brushing the horse or they're petting the horse, music can be a great thing. But if they're trying to do two things, it may be a little bit much. How does diet affect dementia? Well, again, it depends on what the disease is that's causing dementia symptoms. In an Alzheimer's dementia, then diet, we attempt to limit sugars and fats. I know they talk about what's good for the brain, what's good for the heart is good for the brain. So that's what we kind of focus on, especially in someone that's in an earlier diagnosis, is keeping the body healthy. It benefits the brain. Unfortunately, once someone has an Alzheimer's type dementia, the spread of that, the effect that that's going to have, very little has to do with what you're eating. We do attempt to try to keep people healthy. So whatever is good for the body is good for the brain, and that's kind of the diet motto that we follow in a lot of our Alzheimer's care. Another question is, should you correct a stroke victim when they are in their past? No, I don't. I don't correct anybody when they're in their past. Bringing them sometimes to the present is scary and it's mean, especially for some of our Alzheimer's or stroke patients that are still getting a grasp on reality. I always go to them and spend whatever time I have wherever they are. And sometimes they look at me and say, that's not right. We're here. And I say, yeah, that's right. So going with them wherever they travel seems to be the best way to go about that. So I really do try to not correct necessarily, but just meet them where they are. If they look confused and are looking to you for an answer, go ahead and give them that honest answer. You're going to also get to know your clients better and know who can handle things and who can't. Another question is, we're considering developing a driving program with miniature horses for seniors, thinking this would be safer than riding and the small horse side would be less threatening and easier for them to engage. My thoughts. I think if you can do anything safely with seniors of any age, you go for it. We are seeing a difference in the senior population, period. People are willing to try new things. If you can do something in a safe manner, then absolutely go for it. We have horses. We have a number of horse farms here. I'm out near Saratoga, New York. So we do engage a lot of our Alzheimer's and seniors out in some of the horse programs that are available. And as you all know, horses can be therapy all in of themselves. So we use that a lot. So if you're considering developing that, certainly give that a go. I'd be really interested to see how that goes. Any other questions?
Debbie, it would appear no other additional questions from our attendee sites. So do you have any closing thoughts in a quick moment or two before we wrap up this portion of the session and move forward into the breakouts?
No, I just want to say thank you all so much for attending and for really taking a chance on, working with some people with Alzheimer's and dementia. I know some people are a little hesitant to do that, but believe me, the benefit they get is just absolutely huge, and we really, really appreciate all of you for what you're doing and for your dedication to the education and, trying to reach out to the Alzheimer's dementia population. So thank you.